Hello, I'm Dr. Anurag Bajpai, a pediatric endocrinologist from Regency Center for Diabetes, Endocrinology and Research. And today I'll talk about a very, very important problem of precocious puberty in girls. Precocious puberty in girls is defined as the onset of breast development or pubic hair before 8 years of age and menarche or vaginal bleeding before 9.5 years of age. When identified at the right time, precocious puberty treatment can result in significant improvement in the long-term outcome. Delayed diagnosis and management has significant implications in terms of the outcome. There have been increasing awareness with regards to precocious puberty in girls, and people are becoming more concerned about it. However, there seems to be a general impression across not only the medical as well as the lay fraternity that precocious puberty in girls is common, and therefore it does not require extensive evaluation or management. We keep on reading in the various newspapers as well as the various media which talk about the greater incidence of precocious puberty which is being seen in girls and related to a lot of lifestyle issues. While we are witnessing a slightly earlier onset of puberty, we should understand that the onset of puberty before the prescribed norms, that is definitely an issue of concern. If we do not identify the condition at the right time, it can have significant implications in terms of physical, psychological and social outcomes of an individual. The major effect is on the height. During the course of precocious puberty, we often see that the girls are tall, but when they come to us, we find that their bone ages are very advanced. So while they are growing fast, their bones are growing faster, and therefore they have a high risk of compromised height. Puberty in a girl is a systematic process which follows a definite schedule. So the pubertal development in girls starts off with breast development typically happening at around 10 years of age, progressing over a 2-year period to menarche. The process of puberty is tightly regulated by 3 major organs: the hypothalamus, situated in the brain, the pituitary and the ovaries. The gonadotropin-releasing hormone produced by the hypothalamus is the key regulator of pubertal regulation, and it acts on the pituitary to produce luteinizing and follicle-stimulating hormone LH and FSH, which subsequently act on the ovaries to produce estrogen. And it is this estrogen which is responsible for the breast development, for the uterine growth, as well as the bone age maturation. Puberty in girls represents the combination of effects of the gonadarchy, which is the effect of the GnRH, LH, FSH and estradiol, and adrenarchy, which is the effect of hormones being produced by another organ in the body which is very close to the kidneys, known as adrenal glands. These adrenal glands produce DHEAS, which is converted into androgens and is responsible for features like pubic hair growth, change in the odor and acne, which are common in terms of pubertal development. So there is a different regulation, so to speak, of breast development and pubic hair development, and this is something which is important not only from our perspective when we evaluate a girl who comes to precocious puberty, because they will have different causes altogether, but also in terms of treatment which act on the ovarian axis will not have an effect on pubic hair. Most girls who come to us with precocious puberty represent central precocious puberty, in that their puberty is regulated via the abnormalities in the hypothalamus or the pituitary, with very rare girls having primary problems in the ovaries. Fortunately, over 90 to 95% of girls who come to us with precocious puberty do not have a serious underlying cause. Girls with onset of development of puberty before 6 years of age definitely have a much higher chances of having an abnormal disorder and require careful evaluation and management. Other causes of precocious puberty include prolonged untreated hypothyroidism, in which the thyroid is not working and that causes a lot of hormonal changes in the body, different forms of cysts which form in the ovaries, which may be a one-time problem or which may be a recurrent problem, and rarely some of those genetic disorders which have increased activation in terms of either the hypothalamus, the pituitary or the ovaries. The key parts of evaluating a girl who comes to us with precocious puberty include whether this is really a precocious puberty, what is the cause, and whether the girl requires any treatment or not in that perspective. The first issue is, of course, to carefully examine the girl as to whether the development is true or not, especially now with increased prevalence of obesity. We are identifying girls who come to us with increased complaints of breast development, but that's actually fat rather than the breast tissue. Once we have confirmed that this is precocious puberty, we do run a number of tests which tell us about the cause of precocious puberty. They confirm the level and how quick this progression will happen from that perspective. Now, since height is a major cause of concern in a girl with precocious puberty, one of the most important investigations is to look at the bone age, and a very careful assessment of how the bones are maturing becomes important, because that can give us clues as to how long the girl has in terms of growth and how much time growth is there. And then we compare this with parental height to see whether the girl will achieve the predicted family height or not. We may also need to order an ultrasound of the uterus and the ovaries to look at how the uterus is growing and how close a girl may be in terms of the periods. In girls who have an onset before 6 years of age and high levels of luteinizing hormone, we would need to do an MRI of the hypothalamus and pituitary to identify an underlying cause. In older girls, unless we have features of the CNS or the neurological involvement like headache, vomiting, fits, seizures, epilepsy, in those situations we do an MRI. Otherwise, a routine MRI of the brain is not required. The vast majority of girls who come to us with precocious puberty have a central or a gonadotropin dependent precocious puberty, and these are highly amenable to treatment to GnRH analogs. Now, the gonadotropin releasing hormone produced by the hypothalamus acts on the pituitary to produce LH and FSH, which regulates the production of estrogen. The use of long-acting GnRH analogs can desensitize the pituitary, therefore reducing the level of LH-FSH and temporarily stopping the progression of puberty. These agents have been used successfully across the world for the last 30 years in huge number of patients with very successful outcome and safety. In particular, the long-term concerns with regards to fertility, with regards to the bone mass, with regards to the future development of ovarian problems have not been found to be true, and these are absolutely safe drugs to use when they are essential in that regards. So from a clinical perspective, the doctor will decide whether the girl has a rapidly progressive disease, whether this is going to impact in terms of the growth, in terms of psychological factor, or whether you will have significant impact with regards to the overall early onset periods, and these then would require the treatment from that perspective. Usually we use 3 monthly injections which have to be given on that particular date. It's absolutely important to follow the schedule, because if we break the schedule, you may have periods in which the hormonal suppression will go up, and the things will again cause confusion and concern from that perspective. So a regular follow-up along with regular injections is absolutely essential. Usually the main follow-up is with regards to the clinical examination, looking at the height and weight of the girl, and also sometimes looking at the hormonal profile, whether these injections are effectively suppressing puberty, looking at the bone age to look at the progression, and really an ultrasound if required. An important thing to remember that in girls who already come to us that with periods which have already happened, in that scenario, once we give the injections, there may be one period which may happen, because this is already, there is endometrium which is there. So by the time this hormone is working, this endometrium may not be completely resolved, and there could be a withdrawal bleeding. This is not a cause of concern. This is just something which we expect, and we should be prepared. Pubic hair growth is not regulated via estrogen produced via the ovaries, and this is under the regulation of the adrenal hormones. So while treatment with GnRH analogs, we often have complaints that while the breast development has reduced or it's stabilized, the pubic hair development is continuing, and this is something which is expected, and that's something we should not be very much worried about. With the GnRH analog, we expect that the rapid pubertal development will come down, the menstrual cycles will stop, the breast development will stabilize and maybe reduce in size as well, with minimal impact as far as pubic hair is concerned. The growth rate or the height in that period should go back to what is the prepubertal growth rate, which is around 6 centimeters per year, And rapid growth would actually mean that we are not treating well. The typical duration of treatment of GnRH analog is still around 10 to 11 years. And that is the time when we start thinking that now how much is the potential of height, how much is the psychological maturity of the girl, and then we decide about discontinuation of treatment. Once we stop the GnRH analog treatment, we expect the overall process of development to restart, and we expect that the development will happen over a period of approximately 1.5 to 2 years. Girls who have had vaginal bleeding to begin with before treatment would definitely have a bleeding in 6 to 12 months, while other girls may take a longer period.